Okay, we're gonna go ahead and get started. Thank you everyone for joining today. So, it is our pleasure to welcome you to another NIRx webinar and to host Dr. Jorge Zuniga, who will be talking about his latest research using fNIRS in children with congenital limb loss. So, the title of his talk today is The Sweet Spot for Motor Learning, an fNIRS study in children with congenital limb loss. It is my pleasure to host and moderate this webinar with our wonderful support administrator, Theodora. So for those of you joining us for the first time, welcome. We are NIRx, a leading fNIRS manufacturer, and for over 20 years, we have been committed to supporting our users in every possible way. And these webinars are just one example of how we bring our community together to share ideas, questions, and insights. To those who have joined our webinars before, welcome back. So we are always excited to stay connected with our users and customers. So this year we are attending many conferences and hosting several workshops. So please follow us on our social media and come meet us in person at upcoming events. If you would like to stay updated on our latest publications, product releases, and company news, you can subscribe to our newsletter using this QR code. We only send it out to you 2 to 3 times a year, so we promise not to spam you. Before we get started with the webinar, I would like to mention a few housekeeping notes. So you are all muted, and you are all welcome to interact with Dr. Zuniga and with us through the chat. So if you have any questions, please feel free to put them in the chat. I will collect them, and then at the end, I will read some of the questions that have already been submitted and some of the questions that you might have during the webinar. Also, the content will be available on our website and on our YouTube channel in the next few days. And if you have any other questions, for example, we are out of time, or you think about the webinar again, or you didn't have the chance to join it, please do not hesitate to contact us through our consulting and support emails. So now, without further ado, it is my pleasure to introduce Dr. Jorge Zuniga. So Dr. Zuniga earned his Master of Science degree from the University of Nebraska at Omaha and his PhD from the University of Nebraska at Lincoln. He is currently a faculty member in the Department of Biomechanics at the University of Nebraska at Omaha and serves as the director of the Additive Manufacturing Laboratory at UNO. Dr. Zuniga's research focuses on advancing 3D printing technology for medical applications, including the development of low-cost 3D printed prostheses, 3D printed anatomical models for surgical planning, and the creation of novel antimicrobial materials for 3D printing. His work has been funded by NASA, the National Institutes of Health, and various industry partners, and he has co-authored over 100 peer-reviewed scientific publications. One of his most notable contributions is the development of the Cyborg Beast, a 3D printed prosthetic hand for children, which has recognized by MSN as one of the top 5 inventions of 2014. His innovative research and international collaborations earned him the distinction of 2018 runner-up for the Science Prize for Innovation, Research, and Education, an award presented by the US Department of State. Dr. Zuniga's ultimate goal is to provide quantifiable evidence of use-dependent neuroplasticity, integrating prosthetic training with neuroimaging-based assessments to improve rehabilitation outcomes for children with limb loss. With that, I would like to hand in the virtual mic to Dr. Zuniga and looking forward to your presentation.
All right, just give me 1 second to share some things here. Okay. All right. Antonellis, everything is looking fine? Right there? Perfect. Thank you so much for the introduction. It is my pleasure to talk to all of you about something that I feel very strongly about, something that it wakes me up at night thinking of about how to improve it. Before we dive into it, I want to give you a little background to the place where I work. So, but before that, I want to give you a little advice. So this my disclosure information, this research that you're gonna see and we're gonna talk about, it is funded by the National Institute of Health, um, and that's the main source of funding. I want to talk to you a little bit about the place where I work. So we're located here in Nebraska, in the geographical center of the United States. So if you see the map and you put your finger in there, in the middle of the map, you're going to find Nebraska. And in Nebraska, we have this amazing biomechanics research building. Is right now is the largest biomechanics research building in the world, which is fully dedicated to research in biomechanics and from different areas, going from motion, the study of human motion, to biological inspired robotics, all the way to rehabilitation and development of new uh, prosthetic devices. I know most presenters put the thank you slide at the very end, but I'm a little bit different, so I'm gonna go ahead and put it right on front, just because I don't want to neglect forgetting those of you that I know that you're presented already, you're here listening to this presentation, uh, specifically the team that was involved in the research that I'm gonna be talking about. I know that Dr. Borrell is here from Kansas University Medical Center. He did his postdoc in my laboratory, and he's mentioned on some of the research. Dr. Arun as well, that is one of the persons that really help in the analysis of our fNIRS data, graduate assistants, and the collaborators that make this possible, highlighting Dr. Ted Happert, that kind of give us an introduction to this fNIRS analysis that I'm going to talk about, and also NIRx. You know, they were extremely helpful in helping us, achieving our research goals. You know, and we're going to talk a little bit about that too. So just a background of some of the things we do in our laboratory. We really, as a biomechanist, we're really fascinated by movement, and specifically restore movement. And some of the videos I'm showing you here are pediatric patients that are missing their limbs. So the population we work with are individuals with upper limb reduction deficiency. So this is congenital. What this means are children that are born without their limbs, with missing limbs. So um, this opens a window, a fantastic window of understanding what would happen to a human, Think about this. What happens to a human when they are born without a limb? And we're going to talk more about this, but we have these cortical representations in our brain of our hands, of our body, of our lower limbs, our face, and so on in the cortex. But the question here that we're going to be talking later on, and I'm going to explain how we got to that point, is if you're born, let's say, without a limb, how well structured is that representation in your cortex, let's say motor cortex, right? And that's kind of the domain we're going to be talking about. So some of the device is completely related to the device use. So what you see here are children that are missing those limbs, and you see a mix of electronic driven device. The first picture I show you is an electronically driven device, and what that device does is basically assist the child on the movement. So the first video that you're seeing, the child, the participant, our research participant is mechanically pushing down. He has a little bit of wrist, so he's missing his digits. He's pushing down a little bit, and is activating a series of real-time feedback in which the actuation system is helping him to complete the grasp, improving strength. Because we notice that with the devices we make are mechanically driven, most of them, but we notice that when at the last point of grabbing objects, the strength is lower. So we develop these devices kind of to maximize the strength and the grasping action. Then you see a series of devices that are also mechanical. So the first two videos on top are partial hand prosthesis, and then the third video on top is a transradial device. Those are devices for children that are missing the limb below the elbow. And you see the patient with the pink arm there. As she flexes the elbow mechanically, this is all mechanical, the fingers close up, right? And she's able to grasp small cubes and move them from side to side. That's the box and block test. And then you see devices that are related. This last device, you should see this patient, that's wearing blue and is throwing a basketball. That device is very particular. It's a device that we designed to assist with the improvement of basketball shooting. So he's a basketball player that lost in a lawnmower accident. He lost two of his fingers with ulnar nerve damage, which didn't let him extend those fingers. So what the device you see there is a device that is designed to allow him to shoot the ball, the basketball, follow through, and improve the backspin of the basketball to improve his shooting accuracy, right? So those are kind of a good examples of the type of work we do. Now you may be wondering at this point, what that this has to do with the brain? Well, once again, as a biomechanist, those are questions that we ask. I teach some of the courses. I teach a course called neuromechanics, and I used to teach motor development, motor control, and motor learning. So those are areas that are kind of trying to examine and trying to understand what happens to the brain as we acquire a skill. And you would agree that using this prosthesis is just like that, right? You're learning a skill. And for those of you that have both arms and both hands, let me tell you that using this sort of prosthesis is kind of difficult. There is a lot of engagement. There is a lot of motor activation that has to happen, in a lot of motor control, a motor learning that has to happen to improve the function of these devices, right? So I want to show you this video because it's absolutely fascinating. This whole research with brain analysis started with this video you're seeing here. The video you're seeing here is a young child that's using one of these mechanical prosthetic devices for the first time. So this young child has never, ever, ever used a prosthesis, right? And what you see, I want you to look at the arrow. Look at the arrow and tell me what you see. So if you look at the arrow, you see some mirroring action, some mirroring activity. What that is that she is almost initiating and replicating the movement of the prosthesis with the non-affected hand. Now, mirroring movements are developmental and they're normal for young children. You see this happening, right? It's not a big deal. But our observations while making these devices for people, and let me tell you, we have a very large and extensive type of population of subjects. Our observations were indicating that this continue until adulthood for some of them. So we were wondering, okay, what's happening here? If it is it like individuals with upper limb reduction deficiency maybe trying to access motor programs or maybe the cortical representation of the ipsilateral side, of that side that's unaffected? Is it that, or is just purely developmental? What's going on with the brain when you give an individual an artificial limb while they have never had one? And based on observations, you have many, many questions. So, but this was the video that kind of initiated, our research. And the first thing we tried to understand is brain lateralization. But before we go there, in the practical sense, and I want to speak to those folks that maybe are not neuroimaging experts. I mean, I would understand that the people attending the seminar would have a basic understanding of neuroimaging. But if you're like me, back in the day, years ago when we started this research, I can tell you that I wasn't formally trained as a neuroimaging, as a biomechanist, with questions about how the brain works. So from that perspective, I was wondering how we're gonna study the brain of young children. So let me tell you very fast how we got to this point, because as I said, we live in Nebraska, and we have a very large medical center, the University of Nebraska Medical Center, which is right next to our biomechanics building. It's very, very close. So we have access to all that type of infrastructure. And let me tell you something. The first type of neuroimaging technique I was trying to learn how to examine this was the MEG. So I spent the whole summer doing a training with how to use MEG, magnetoencephalography. And let me tell you that in my experience, right, things may have changed, but when I was learning this, the setup to detect the region of interest, to get the markups, get the areas of the brain you're going to analyze ready for imaging, it took 45 minutes. So my question was, how am I going to get a 6-year-old, that's kind of the younger age group we work with, sitting on this chair, not really moving, and having a setup of 45 minutes? Very, very, very difficult. So then we moved to something else, and I moved to fMRI, because that's what most people were doing with adults, right? And then my problem here, at least in the United States, is that per each session first of all, it's very noisy. I was afraid that our children were going to get scared on. Plus, our institutional review board, that's ethics, required us to have training fMRI, so kind of build an fMRI that's in miniature, that is for training children, to show them the activities before actually doing the fMRI. But then the other part is the cost, right? Because we had to pay about $700 for access. So it wouldn't work for each session. So it wouldn't work. Then we moved to something more bench, like a bench setting, portable system. We look at EEG. We tried some pilots with our children. I'm sure people do this, but remember, we were very naive back in the day, inexperienced. We tried to use it. It didn't work. The noise, the movement was complicated in our pilot data. We were not successful. And this is just us. I'm not talking about everyone, but this is just us. I'm talking about my reality, right? But then we got to know fNIRS, and this really, really, really solved a lot of our problems, because it was a portable system. So we use the Sports 2, fNIRS Sports 2, and we have two systems, and we're maybe trying to get a third. And what happens, we were able to accomplish a lot of our objective. And I remember in 2020, we were able to take the system into isolated units. We did a project about children with immune dysregulation, with severe immune dysregulation and their motor skills. And they typically get the treatment in isolated units, and they're isolated from family members and so on. And we wanted to understand, what the brain activity, how would this affect their motor skills and development. And this is probably the only system that we were able to get it approved to take it inside of isolated units because it was easy to sanitize and so on. And it's a portable system. So it really gave us an opportunity to do all the things that I'm going to be talking about. And I think mentioning this is important because a lot of you are thinking in other modes. And when you work in pediatric subjects, this was a very, very good solution. Okay, so talking about brain lateralization, we really wanted to understand, first, we know that the left hemisphere controls the right and vice versa. For the most part, right, is very well reported in the literature. But because of these mirroring activities that we kept seeing over and over and over, even from young children, from adolescents, young adults, and so on, we were wondering, okay, the most simple question to ask was, is this true? Is the contralateral control phenomena that we see, and there are 5 theories of why, more than 5 now, why it's beneficial for the human species and humans in general to have a contralateral control. And we can talk about that, but that would add another half an hour to it. But there is one it has a mathematical model. It's called the mobilization hypothesis, and it gives 5% advantage for humans to have the contralateral control. But under this framework, we wanted to know, does this hold true if your limb first, if your limb never existed, or it was, let's say, some of the congenital cases we have are the umbilical cord that goes around certain parts of the arm and cuts the blood flow and results in amputations before birth or after birth, So we wanted to understand if in this type of population, the contralateral control holds true. So we engaged in this sort of paper, and I'm going to walk you through a little bit in what we did, okay? So we had a relatively small sample. So we have 5 individuals with upper limb reduction deficiency and 5 control groups. And what we did here, we match age and gender and the preference sites, right? So, and then we went a step further and we controlled for device use, right? So when you have a control group, you want them to really mimic all the sort of conditions to the experimental group. And age and gender are the common ones. The usage side is the third one. But then we went one step further of device. So what we end up doing here, we developed a prosthetic simulator that was biomechanically equivalent to the prosthetic device the control was using. And this is what we did. So we set up the fNIRS, both hemispheres, like you would normally do. But then we had those control group doing the box and block test that I showed you earlier, that you saw in the videos earlier, where you move a block from one side to the other in 1 minute, and you count the blocks that are successfully moved with the prosthetic simulator. And what we found is that I'm not showing you the numbers here, I'm showing you the pictures, right? What we found, that the contralateral side was the dominant side, even though you're using a prosthetic simulator, okay? So that's expected, no problems there. Then we had the non-involved hand, so the hand on the other side of the prosthetic simulator. We put all the prosthetic simulators on the left side. So and then we had people using the right side, moving the box and blocks, okay? And then we found something very similar. The dominant hemisphere was the contralateral. That's something you would expect. But then we found something a little bit different. We found a situation in which we had the individuals using the prosthesis, we had that the dominant side was the ipsilateral side. And this is something that we were wondering about, because remember, these subjects we have here are subjects that were congenital, so they never had the left limb, and they have never used a prosthesis. They were new to prosthetic use. And what we found there, we found that the ipsilateral side was activated. Then we did the test with the right hand, and we found that it was the contralateral. So the only thing here that was different is the ipsilateral control of those using a prosthetic device. Now, let me tell you, so this is, in terms of the population, this is new, but this phenomena of ipsilateral control is widely reported in the literature. So if you look at individuals, for example, with the stroke patients, this has been reported a number of times in stroke patients. But strokes are so super different than limb loss, because a stroke is an injury to the central nervous system in the brain, right? This is the peripheral nervous system is outside. But somehow, and we're going to talk more about this, somehow, uh, the sensory neglect of missing a limb, the responses are very somehow similar to what may happen to an injury directly in the brain. Not completely similar, but somehow similar, specifically in terms of contralateral control. I know that you may have a lot of questions about, we use the laterality index to measure this, but I wanna give you some references, and I'm gonna be doing this a lot on my presentation because I think it's very important for you to have the proper literature. So we did, as Dr. Borret led a study where we did all these different, the general linear model and the block analysis type of brain laterality, including positive betas and negative betas on the algorithms. And we found, and you can look at this paper kind of to analyze the different ways that you can measure the laterality index. So that's a very important paper that I think you need to you need to get familiar with if this is something you want to do in your laboratory. Okay, so here's where we are right now. We went ahead, we found ipsilateral control in this type of population. So now what? Well, we thought that maybe this ipsilateral control was abnormal. Now, once again, because this is different, we can't just say it's abnormal. But in order to develop a hypothesis, we took that position, right? Because that's not really what you see in the typical developing population, right? So what we did, we said, okay, can we reverse this? So if it's true that there is an ipsilateral control on this type of population, can this be reversed somehow? And we shows, because we developed this home intervention program for prosthetic users. And we said, what if we have them run, so individuals that have never used a prosthesis, therefore have never engaged in prosthetic training of any kind, what if we put them through one of these trainings and see if things change? So we did that. We grab a young adult, that had a clear ipsilateral control, and then we have her do, I believe this was 8-week program, very intense prosthetic training, and then we found that it was somehow reversed. And there is some literature, if you want to look at the actual details of the home intervention program we developed, I'd be happy to share that information, an actual paper. So you can request that in the chat, put your email, and I'll be able to send you that type of information. So, but this is n equals 1. So that's what you need to be careful about. This is one subject. But so from this point on, we decided to engage in a sort of a large type of research in which we have multiple research subjects, so we can get an idea of what are the pattern of responses of this sort of population in general, right? And something happened. I want to show you this. So what you see here is a picture of my son. So this is my son. And what happened that he was serving as a control group. So we were doing this large type of research in which we were doing with individuals with upper limb reduction deficiency, and we were looking for control groups. And my son happened to be the same age and gender of one of our experimental controls. So he came and we did one of the sessions, right? He came and we did one of those sessions. We did that session with him, and literally the day after, he he had an injury. He playing soccer, he broke his clavicle. So they had to immobilize him for a month. Obviously, after taking him to the doctor and do x-rays and all that stuff, the second thing we did, we brought him back to the lab and did a brain analysis also. So in order to understand disuse, because remember, we believe at the time that the lack of people missing a limb, it was some sort of sensory neglect that would make things change in the brain. But then if that's true, it would mean that if you stop using one of the limbs, the same thing would happen. The brain would change from contralateral, maybe to ipsilateral, from contralateral, bilateral, and then ipsilateral. So we went ahead and did a follow-up research with him for about a year, actually. So let me show you some pictures here, okay? Because I think it's important. And pictures are kind of hard to see sometimes. But let me summarize a little bit of what happened here. So his injured side that got immobilized was his right side. So obviously we don't have data from his right side for the first month, right? Because he was immobilized. We were not able to have him do all those things. But we did use the non-affected side. And in summary, what we found, and I don't know if you can see in the pictures or not, but I can give you a little summary. What we found that, in fact, he went from contralateral control within that month to bilateral. He didn't get to the point of ipsilateral control, but he got to the point of bilateral control. And this could be for many reasons. We believe that because, he was immobilized, it doesn't mean he wasn't really using his hand. Because, to answer text in the phone, you still use your hands a little bit, even though your arm is not moving. That's what we suspect. But in the course of a year, it did go back to contralateral. Again, n equals 1. There's not much. We cannot generalize this information. But and I also know you may have questions about the analysis and all of this. So I really want you to direct you to Dr. Arun, and he's now working at Wisconsin-Madison. He's also he did his postdoc in my lab, and now he's working at as a scientist 2 level in University of Wisconsin-Madison, and he is one of the persons that we hired just to specialize on fNIRS. He did several trainings in France and so on about fNIRS. So he's very well trained. Happy to put you in contact with him because he's the person that did this analysis. All right, so now we're to a point in which we can kind of ask major questions. We have enough data. Some of it is empirical data, but some of them is scientific observations based on the case studies I show you. I have more, but I'm not showing you all of them, as I'm showing you the ones that I think are more relevant for this talk. But then now we can kind of ask questions that are more broad and more general. And and I wanna go back to what I said earlier. I said earlier, the way how the brain is structured in terms of cortical representations. Uh, is this hardwired? Is this that you're born? Are humans just born with all these cortical representations in certain areas because are genetically predisposed to that, or are those developmental? Are those cortical areas maybe developmental in terms of as you move, they develop and emerge? And I know some of you experts in motor control and motor development, even a little bit of motor learning, would have your own ideas. But when you look into the literature, is you come up with certain groups around the world that are kind of trying to answer the same question, or questions that are somehow similar. So I wanna introduce you to a group that we follow very closely, very closely. And this is Dr. Tamar Makin from the UK. And one of the papers that she wrote that really kind of helped us understanding, you know, she does a lot of the research she does. She uses fMRI, but she does it with adults, you know. She also has some papers in which she does research with up, upper limb reduction deficiency on adults, but also amputations as well. And amputations are meaning due to accident. Most of the amputations these days are due to cardiovascular, so diabetes and so on. But on this paper, she talked about few main things, and I'm putting the paper there so maybe you can get a screenshot of it because it really if you're interested, if you have an interest in this domain, you will find this useful. When you read this paper, there are a few things that we learn. Number one, that the missing hand territory represents multiple compensatory body parts. Remember, so this is if you are born without a limb, it appears that that area of the brain is populated by other body parts in a compensation, in a compensatory strategy. I'm going to show you a couple of videos for you to understand this because it's absolutely fascinating. You're going to love it. The second question we learned is that the brain plasticity seems to be driven by functional use, not just cortical proximity. And I'm going to talk, and this is related to those findings, and I'm sure if you follow this research, you know this. Those findings that when people are missing limbs due to trauma, most of them, when they miss a limb, a lot of them express phantom limb pain when stimulated in the face and in the lips around the mouth. This is well reported. Is the fact that when people are stimulating the lips, they express a lot of phantom pain on that missing limb. And researchers like me, have been trying to answer this question forever. There are textbooks kind of explaining what this is all about, and what Dr. Makin is saying that those cortical representations may be driven by function, not just the proximity, because that's the answer we had. And that's the answer that other neuroimaging experts looking into this, they had. They said, well, the area of the mouth is very, very close to the cortical representation of your hands. So it makes sense that proximity is populating that area. It's expanding the area of your face and your lips. But once again, what Dr. Making research is pointing out to something different. She's saying, no, it's driven by function. The third thing she talks about in adults is that there is a reduced GABA, which is gamma aminobutyric acid, is a inhibitory neurotransmitter in the brain. Does a lot of different things, but one of those things it does is inhibition. So one of the reasons, there's many, but one of the reasons that your left hemisphere is not really communicating with the right, they do, but not broadly speaking, is because GABA inhibits the communication of the left and right hemispheres. And she's saying that the reduced GABA levels has been shown in the missing hand regions, facilitating reorganization. So she's pointing out to a physiological aspect of it, which changes. And let me tell you something. When you are somebody like me that's trying to answer questions, and we're very, in a very genuine way, when you read work like this and with quantitative data of this magnitude, it makes you very excited. I want you to watch the following videos and tell me what you can't speak, but watch these videos. Look at this. They're going very fast, but so you're seeing somebody opening a bottle of water, and they're wearing a prosthesis. This is, by the way, these are various videos from Dr. Makin's lab. They're not my videos. And you have another subject that's doing activities but not using a prosthesis. So what you see here in all those videos, you see few things. You see, and that's what I'm saying as a scientist, having the ability of observation is so important. And that's why I highly recommend those of you that are starting your careers as scientists. I understand that reading the literature is super important. You can't miss that. I get it. But sit in your lab and observe the things that are happening. Because remember the video I showed you of the young child moving the prosthesis, and the mirror movements initiated all of this. And the videos I show you here are showing that people with prosthesis, one, they use the non-affected side to manipulate, and the prosthesis usually stabilizes the objects. But I want you to remember the first video you saw with the people opening a bag of chips. I don't know if you remember this bag of chips. Well, how do you open a bag of chips? What I do, grab the bag of chips and I use both of my hands and open it. Let's see this first video again and tell me how this person is doing it. It's super fast. Look at how this person is doing it, because I think it's super, super important. Yes, you're correct. That person used his mouth. You see what I mean? That speaks to Dr. Makin's results. She said his function drives the population of the missing cortical representation, assuming that's missing, right? Of the missing hand. So typically we have both hands, and that's why the sensory input and function drives the enhancement of our cortical representation. But when you don't and you use your mouth, that's one of the things that would explain why when you're missing an arm and you provide some sensory input into your mouth, you may increase your phantom limb pain. Is because your mouth is acting like the missing hand. So it proves Dr. Makin's theory true. Now, of course, we don't know yet. So one of the things I try to do with this is trying to find out, as a motor, as somebody that's familiar with motor learning, motor control, motor development, and in general, neuromechanics. I wanted to find what's kind of the sweet spot of motor learning. This is a phenomenon that we keep seeing with our subjects. They come, never use a prosthesis. They come and we give them a prosthesis, and they have issues using it. A lot of the rejection rate, which in this population is very, very, very high, up to 58% rejection, meaning you give them a prosthesis, but then they don't use it, is because they're difficult to use. It's because the training process is difficult, and they can do activities without the prosthesis, even better sometimes. But we know that if you continue doing that in the course of 20 years, overloading one hand, is very likely you get overuse injuries, compensation strategies that are just not good for you in terms of injuries and overuse injuries. So it's very important that young children use a prosthesis to avoid these problems along the future, right? And many other reasons. There are many other reasons, developmental reasons too. But in particular, we wanted to see how they learn. And we asked something very specific. We figured it out a little bit that learning is driven by practice, like all of you guys know. But also we know that maybe the complexity accelerates the process of learning and neuroplasticity. I'm sorry, accelerate the neuroplastic changes. Sometimes not the learning. The learning comes later. So we decided, based on all the information I share with you, to study answer the question: what is the right amount of adult assistance needed for a child to perform a complex task? And this is not a new question. As a scientist, I'm big in history. I like to read back the research from the 1950s and above and trying to understand what are the gaps that are relevant now, but sometimes they were missed back by past big old scientists, you know, the shoulders of the giants in scientific aspect. And I found that this question that we had was formulated in the 1900s by Vygotsky. And he observed that children have an inherent attraction for behaviors that are perceived to be beyond their capabilities. And you can see this in sports, you can see this in your real life. So when you go to a place, you go to a meeting, you go to for a lunch with somebody, and you're talking with this person about something, and if you're not learning anything new, you get you lose your engagement. You start getting bored. But when you go to a lunch or you have a meeting with somebody that's giving you new information that you didn't know before, you are engaged and you're motivated and you want to keep going and learning, continue that. So children are the same way. And evolutionary, we know they are driven to reach the next developmental stage. And one of the big motivators in sports and rehabilitation is learning, is knowing that you're doing something that you're improving. Operationally speaking, is the domain, the proximal development is the domain between what is known and what is not known, right in between. It's right where we believe is the sweet spot for motor learning as well. And I'm going to show you some data about this. So the purpose of this study was to examine practice-induced neuroplastic changes using fNIRS, and in particular it was with fNIRS, before and after a prosthetic home intervention. And this was based in the zone of proximal development. So what that means that we were making our participants using prosthesis and the control group, prosthetic simulators, because we did have a control group, things that were very complex. But then we have caregiving individual, the parents, family members that which we train side by side. So when the child absolutely needed help, they provided assistance. But we didn't let them assist them right away. We kind of wait to the point of frustration, you know. So it was and this home program was guided by occupational therapists that they do this for living, right? So they know very well how to do this. I'm gonna share some information with you here. So the total sample size for experimental, this is an ongoing research, so we're collecting data as we speak. But this is the data we have so far, which I'm presenting right now, right? Is we had 12 individuals, experimental group, and 8 control groups. And the same thing holds true, like we talked earlier. They were individuals, age, gender, match, and with a prosthetic simulator to match device use. Hold on, a couple more things I need to say. In terms of function, we had the experimental group doing the box and block before and after the intervention, as well as the control group. So both the experimental control group moved these blocks for 1 minute and we count them. Both increased. They both went, for example, the experimental group went from 7 blocks to almost 12, and the control group went from 7 blocks to about 12 blocks. So the 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 skills were very similar on those groups. Now I know what you're thinking. You're looking at the age, and you're saying, "Oh my gosh, this age group is all over the place." Yes, it is. 6, the youngest, and the oldest was 16 years of age. I understand. I know that there are developmental difference. I know all of that. I just wanted to get a blueprint of how young children of this age group responds to this intervention. That's all my objective here with my research team. So we had an 8x8 setup with the fNIRS, and in order to do our analysis, a lot of was done using the C-scores that, as you're going to see later, we transform those to R values, so it's easy to explain and understand, But the setup was, they come and do the box and block. So we did fNIRS during resting, then did fNIRS during the box and block, during baseline, and then after the box and block. Then they went through this whole 8-week intervention program, and we repeated the baseline, basically. And then the home so I want to give you this paper. So if you want to look in details what the home intervention was, you can obviously look at this paper here. But the home intervention were activities that they will typically do, such as building blocks, utensils activities, paper activities, ball play activities. They carry a tray, bike circuit in a figure 8. We standardize all those activities to provide scores and times, right? And this paper really explains, the validity of the things we did. But I want to give you some results to give you an idea. You see a bunch of figures here, but I want you to focus on the top figures. The top figures show the complexity levels of the activities. So, your y-axis is time, the x-axis is the number of weeks. So if you look at the red line, you see that the red line is going up and up and up. That's the time. Those were the activities that were more complex. The blue line are the activities that were less complex. But you can see how the activity of the blue line is going down and down and down. That's because those activities were less complicated. So they would keep getting faster and faster and faster. But as they did that, we then made them do an upgrade of those activities to make them more difficult. So it would take them longer and longer. That's kind of an example of the top graph. Now, when you look at the bottom graph, the bottom graph is independence measurements. So in this case, PMIF stands for prosthetic measurement of independent function. We adapted this out of a scale and show how independent they were from a scale 1 to 7. And the way you will measure that is by the interaction with the caregiver. So if the caregiver, for example, have to help him hand over hand and literally help him doing the activities, you'll get a score, you'll get a score of 1. But if the child was completely independent without any help, they'll get a score of 7. So that's why you see that the blue line, easy activity, that's complex, super, they reach a score of 7 right away. But then the more complicated activities on the red line, their score kind of went up and down, right? So they needed more assistance and more assistance. So right in between those, between easy activities and hard activities, right in between is where the zone of proximal development. We truly believe that when you do things that are complicated and you are engaged, you learn quicker because the neuroplasticity is enhanced and facilitated by the complexity of the activity. That's what the whole project was. And now we have the results that I want to talk to you about. So then we compared, you know, those are resting, the connections, you know, the functional connectivity during resting. And the first analysis we did was taking the upper limb reduction with the typical developing children, just to see if there were some differences. And if you're listening to this right now, and if you have this amazing breakthrough hypothesis that you can deduct from our data, please reach out, because we're still trying to make some sense of this. And this is what we found. We found that the children with upper limb reduction deficiency, and keep in mind that we group, these are average values of children with different age groups. And I understand that violates a lot of rules of developmental aspects, but it's important for us to get this information to develop hypotheses, because we need to understand what's the general blueprint of this type of population. And you can see here that in terms of the primary motor cortex, it's a big change. So the upper limb reduction deficiency only had values that were higher than 0.7, which we consider, you know, strong. When we went from 2 channels that reached that level, from upper limb reduction, to about 10 channels. So I'm looking at the primary motor cortex, right? So the connectivity, and this is the connectivity between hemispheres, right? Between left and right hemispheres. We see that typical developing children have a higher number of connections that are strong as compared to typical developing children. The other one, and that's the most dramatic one, right? But I want to, and we're still trying to understand this, and the common answer we get is that possibly it may be related to those cortical representations, right? So we're going to move back to the main analysis here. And this is the main analysis, and here we're going to hopefully spend a couple minutes, is the baseline. We have baseline and follow-up. And the major change here that you see on those numbers is the premotor area. Yes, there is some changes in the primary motor cortex, yes, but there is also a significant change, and you can see on that red line in terms of strength on the front of the brain, the premotor area. So when you look at this data, you may wondering why is this happening? Why is the premotor area shows connections that are much stronger than baseline? And when you look at the physiology of the brain, you found this. You found that the premotor cortex is divided between 2 main areas. You have the supplementary motor area, which are driven by motor planning. So both of those premotor cortex, their main job, their main function is motor planning. But the supplementary motor area is a specific control the activation of the programs involved in sequences, while the premotor cortex control movements that are related to associative learning. And those are the 2 main things that children had to really work in this home intervention. You see what I mean? So our hypothesis is that what we're thinking at this moment, we're thinking that motor planning is one of the main areas that children with upper limb reduction deficiency are lacking. And we believe that maybe we don't know if the cortical representation is there or not. If it's there, is not being activated, it's not being used. And therefore, the planning of motor programs is affected. So this hypothesis is supported by data from the 1980s, which shows that blood flow is, and on these regions are really expressed and activated during complex finger movements. And I can share some of this literature with you. And I can see that I'm running out of time, but we believe that if that is a theory that explains, you know, the lack maybe of motor programs on this sort of populations is due to experiential programming, and we are using the theory of the neural group selection theory to understand this phenomena. And this theory from Elderman and now revived by the author Haders Algra. Haders Algra is a researcher from the Netherlands that specifically look at this, and he has some recent literature on this. Help us understand that if you don't have on those early ages, you don't have the early stages of a child in which everything is driven experientially. So as you experience new movements and do more things, these motor programs are getting reinforced and restrained in order for you to develop. So when you have to solve a new problem, you use the best strategy that you have in your brain based on previous experiences. So if you do not have a limb, for sure those experiences are going to be diminished. And I'm kind of racing through this because I noticed that we're kind of getting a little bit out of time. But I want to express that the mechanism of action that we're speculating here, folks. We're speculating. We don't know. But we believe, based on previous literature, specifically Dr. Making from the Plasticity Lab in UK, that reduced levels of inhibitory amino acids, GABA, could be one of the factors that are driving, not only the laterality, but are driving the higher connection in the motor areas and so on that I show you. What happens that in children, it is reported that in children they have lower inhibition, so their GABA levels are much lower. Therefore, the inhibition is much lower. So at those ages I show you, there are also high concentrations of GABA that also are expressed in children missing limbs. So we have two factors that are maximizing this inhibition that we believe drives the results of our study. And clinical implications, we can say that to facilitate motor learning, do not assist children with those tasks that they can do independently. It's a very important thing. And minimally assisting children on those tasks beyond their capabilities facilitates motor learning. So with this, I'm going to skip my current research here and go right to some questions. So
yeah. So yeah, thank you so much, Dr. Zuniga, for the wonderful talk. So the floor now is open for questions. So please feel to drop your questions in the chat, or feel free to raise your hand and unmute yourself to ask directly. And while we wait, I will get us started with a few questions that came in during the registration process. So one question was, can you provide any insights and guidance on applying these methods to motor learning in adults?
yes, so in terms of adults, we now know that adults also experience high capabilities of neuroplasticity. So, and this is the beautiful thing of doing research with pediatric population, because you can also replicate the same sort of methodology to adults, specifically elderly too. And I would certainly replicate the methodology that we have. Of course, the activities have to be different, but in terms of the methodology of engaging into the measurement part of it, it could be identical to what I just showed here. It's not different. And in terms of the activities, you do have to kind of adjust the activities they do to their obviously activities of daily living. And there are multiple tools as assessments you can do with that. But the good news is that there's not much difference.
Another question that came up was if you have any insights, guidance on applying this if you have any recommendations on what are the most robust methods for measuring symmetry and exponential learning trends.
Yeah, I looked into that, and I'm providing a little bit of two references that I think are kind of important. one reference is the number one reference is some new methods of symmetry and the calculations, which you can see here in my screen. That's number one. And then from learning, I will direct you to the research of Dr. Newell. And these are the big names, you know, that kind of address those questions. I'm not going to pretend that I'm going to cite my own research on this, but for sure, look at Dr. Newell, mechanism of skill acquisition research.
Okay, it seems we are just about time. Are there any other questions? I don't see any other questions coming from the chat. So once again, I would like to thank you so much, Dr. Zuniga, for your time and for sharing your insights with us today. And thank you to everyone who joined us. And we look forward to see you at the future webinar. Bye, everyone.